Hi, this is Dr. Bob Dannenhoffer with another of our Facebook Live events. Welcome to tonight. I have my mask on here as I usually do when I'm out in public, but now I'm adequately socially distanced, so I'm going to take it down. And also then people can read my lips. So this is our 23rd Facebook Live event. So we started doing these back on March 13th. And we'll take a little time tonight to review things that have happened since then. But as typical, we'll start off with what's happening. Well, this is still a very, very, very active pandemic. We're now over 6 million cases. And yesterday was the day we had our most new cases ever. Still incredibly active in the US and in Brazil and other places. We have 360,000 deaths. So about 6% of the cases have ended in death, which is still a very high death rate, suggesting that we're missing many mildly symptomatic or asymptomatic cases. Brazil is just a treacherous thing. They're seeing over 25,000 cases a day, and it's thought that those cases are way undercounted. Their test positivity rate is 50%. Remember, we've said in the past you'd like to get the test positivity rate down to 5% or less than 2%. They have a 50% positivity rate, meaning that they must be missing a tremendous number of cases. Even in half the deaths, they have not been tested for COVID. So likely the situation in Brazil is even more dire than is reported in the statistics. And that's worrisome because we were hoping that in the summertime the disease would decrease, but Brazil, being equatorial, would suggest that the heat is not going to help it that much. We're also seeing a big outbreak in Qatar, a country in the Middle East. They have a very high case rate but a low death rate. And this is thought because it's being brought in by workers who are coming from outside the country to come in and do the work, especially construction work in Qatar. And the concern with this is how in the world, when we get this going, are we going to be able to have people come from other countries, and what will that do to rates in those countries? We've also very carefully been following Sweden. As you remember, Sweden has taken a somewhat different approach versus the other countries in Europe. They've taken a much less restrictive approach, although still pretty restrictive. They've closed schools and stopped some big gatherings, but they've allowed restaurants and other things to be open. Its neighbors on each side, Norway and Finland, have done more what the European Union has done with more restrictions. And what we've seen in Sweden is they now have the 8th highest death rate in the world, which is really high compared to the 30th and 40th down in Finland and Norway. And they have about 10 times the death rate of Norway and Finland. So perhaps in the long run they'll have fewer cases later on because they had more cases earlier, but at least the Swedish experiment to this point is not looking so good. And then we're seeing big outbreaks in the weirdest of places: Peru, Bangladesh, Pakistan, and especially now we're worried about India. You know, India, big, very populous country, very tightly packed, and they're starting to see lots of cases. We're also concerned in India that there may be some significant undercounting. In the US, we're at 1.8 million cases, and sadly this week we hit 100,000 deaths. Still in this, we're doing a little bit better, but we still have a 10% test positivity rate. Remember, the goal would get to be less than 5 or less than 2. And it's still really active in a lot of states, and especially we're now starting to see rural areas of states starting to really show up with a lot of cases. So rural Alabama this week was a problem. There were some places in rural Arkansas, and then I saw today that North Dakota had a fast rate. So this is still pretty active. We are definitely not past phase 1 in the rest of the country. Now, Oregon is doing much better and has always done much better. So you remember early on we talked about flattening the curve, and when you see a picture of this, it looked like this sharp peak. Well, I've been doing all kinds of nerdy things, but one of the things I did the graph here of new cases in Oregon. And if that's not a flattened curve, I don't know what is. So starting here in March and going till yesterday, you can see a nice slow flat curve. And that's exactly what we were aiming for back in March when we talked about the things that we would do. Now let's go back to March. When I first did this in March, and I looked at the Facebook Live the other day to see what it looked like. I had a beard back then. But back then, in the entire world, there were only 145,000 cases and only 5,000 deaths. In the U.S., there were only 2,000 cases and 48 deaths. So from 48 deaths to 100,000 deaths. So a 200-fold increase since we've been meeting twice a week here. That really is amazingly stunning. That has not happened with any other disease other than the 1918 pandemic flu. So in Douglas County, what do we got? We have 2 new cases in the past week. We're now to 27 cases. Actually, one of those cases was asymptomatic, so it was already resolved by the time we knew it. That was a person who was being screened prior to surgery and just happened to have an asymptomatic positive test. It's possible that it's a false positive. It's also positive that this was one of the many asymptomatic people. It's hard to know what to do with the asymptomatic people. One was mildly symptomatic, early discovered, easily contacted. A few contacts are now being quarantined. So I think we're doing very, very well. And I think that this bodes well for reopening. Remember, with reopening, we reopened on the 15th. So imagine on the 15th, 16th, or 17th, you went out and got infected. You would be expected then to get symptoms the earliest on the 20th, but anywhere between the 20th and the 24th. When you had symptoms for a day or two, you said, hey, this isn't normal. You'd go in and get your test done a day or two to get the results back. So you'd probably start to see cases from that first weekend during this week. Perhaps one of the cases that we saw was from that first weekend, but in general, I think reopening is going well. And Douglas County today put an application to move to phase 2, and that application was sent in this afternoon, and I'm pretty sure we're going to get it. So the last time we met, there were some questions that I didn't know the answer to. I was doing this in my little home studio. I didn't have quite the fact checkers that we have here. So one of the questions was about Lysol. Will Lysol sprayed in the air get rid of this? I could find no data that it would, and it probably doesn't. You know, the concentration of the disinfectants in the air when you spray with Lysol and you right in the face is pretty low and not enough to go ahead and kill the germs. And the second is, would freezing kill this virus? And I checked that out, and absolutely not. So this virus, as most viruses, freeze very well. And in fact, when we want to go ahead and study a virus later, what we'll do is we'll freeze it in liquid nitrogen, and then months or years later, you can reopen it, and it works again. One of the other questions we'd had was about masks, and I can tell you, I am so sorry for the confusion that we caused, right? It was don't wear a mask, then you should wear a mask, then you must wear masks, and then the World Health Organization came out yesterday with, well, masks won't help that much, and then just that day, a Chinese research said, well, if everybody wore masks, it would decrease it by 80%. Who knows what the right answer is? I think what we do know is that wearing a mask yourself probably won't help you very much, but I think there is pretty good data that if you're in a pre-symptomatic phase or in an early symptomatic phase, the mask really could help the spread to others. So people have made masks a much bigger deal than they are. I think they're worthwhile to do. Just put one on in the morning like I used to put on a tie every day, and as I say to people, if I had a choice of wearing a tie or a mask, I'd always pick the mask. Okay, so let's go to some questions here. So Amy says, what will phase 2 look like? Well, we don't have the full guidelines yet for phase 2, but I think it's going to be a little bit different. I think we're going to have larger gatherings. I think some of the things that are now closed may be allowed to open, like pools. I think there may be increased opening of bars. I think that it's going to, in phase 2, that schools will be allowed to reopen under some rules. So I think phase 2 is a little bit like phase 1, a little bit more relaxed. I don't think there's going to be a phase 3 for a while. Phase 3 is nearly a full reopening, but there may well be a phase 2.1 and 2.2 and 2.3 as we begin to open other things up. One of the real big questions about schools. So I spent a fair amount of time with the college and with the superintendents this week thinking about what schools would be like, and boy, that's still a little hard to imagine because it's going to be a big difference, but we'll work on it. So Rina asks, is it required for everyone to wear masks? No. So it is requested that people wear masks in public, when they can't maintain social distancing. So if you can maintain social distancing, there really is not a reason to wear a mask. But at a time when you can't necessarily maintain social distancing, like when I'm at the grocery store, like when I go to the hardware store, I do wear a mask. You don't need to wear it in the car. You probably don't need to wear it as you're walking down the street. There's no one there. But I think if you can't maintain social distancing, I would certainly do that. It's not required. I think in stores and in retail, it is said to be required, but there's no mask police, so we haven't seen any of that. So, what percentage have we tested of the Douglas County population? So we've done about 2,500 tests. There are about 100,000 people in the county, so we've tested about 2% of the county, and I think that's about right. I think far more important though than the number, and I had this talk about with somebody today. The number of tests really, the percent of tests really makes no sense. So in Rhode Island, where they're having 10 times as many cases as we do, for them to be only testing 2%, 2% of the population total would be way too low. For us, unless you're going to just start testing random people on the street, which is not really recommended, it's going to be really hard to get to the 2% number. So we've tested about 2% of the population, and we have our positivity rate over the whole scheme is only 1.2%, so it's very, very low. So could you please talk about white blood cells in the body's natural immune system that fights viruses and infections? So, the body has this most incredible system that fights infections. So you could imagine as animals evolve, animals that have better immune systems do better because they survive infections than animals that have weak immune systems. So the human body actually has a fairly elaborate system. So there are many kinds of white cells. There are neutrophils, which are white blood cells or leukocytes, and those are cells that go around and scavenge for infection and basically really eat up germs. So if you think of Miss Pac-Man, this is kind of what they do. Those are the kind of white cells that are always there in small amounts in the blood, but come up to really high numbers at a time that your body's fighting infection. They seem to be most effective against fighting bacterial infections, probably somewhat effective in fighting viral infections, but they're really effective in fighting bacterial infections. So very typically, somebody comes in with pneumococcal pneumonia, kind of bacterial pneumonia, they have a white count, which is 2 or 3 times the normal, and those white cells are there trying to fight the infection. Then there are lymphocytes, and lymphocytes are kind of the controller things. T-cell lymphocytes are the kinds of lymphocytes that remember what kind of infections and help your body with cellular immunity, so to have the cells work together. And then B cells are the kind of lymphocytes that produce antibodies. So they produce those proteins called antibodies, which will help fight. And they all work together, and it really is the most amazing thing. And if you tried to come up with a system like this to defend things, it really is incredibly elegant. Or like the clotting system, these phenomenally elegant systems with so many pieces that work together. And usually the way we know how they work is that there are some people who are born with defects in one area or another. So for example, a little guy that I'm taking care of whose B cells do not make antibodies. So he's got like no antibodies, so that we have to give him antibodies to make up for what he's missing. We have other kids, for example, of HIV, whose T-cell lymphocytes don't work. And so they were really prone to infection the days before we had that. Okay, so how do we respond kindly? And I would always say we should respond kindly to those who say, well, more people die from drowning, or more people die from a stroke, so what's the big deal? Well, at least in the last month or so, nobody's died of anything more than COVID. So COVID was the leading cause of death for March and early April. Thank God it's not in April or May. And we do a lot for the other diseases that cause deaths. So It's not like we just let cancer go. We do a tremendous amount to fight cancer. It's not like we just sort of ignore auto accidents. We have tremendous safety things, the whole National Highway Transportation Safety Administration. We do lots of things to prevent all of these things, and they're not contagious. So, cancer is not really contagious from one person to another. But this we are so concerned about, not only because the number of deaths was high, but it's contagious. And as we talk a little later, one person who's sick can infect as many as 20 other people. And so the concern was that this would continue to grow exponentially. Cancer has always been a problem, but it's kind of steady. The reason we worried about this is because this could grow and could grow into a terrible situation like we saw in Italy, like we saw in New York, and I think like we're seeing in Brazil. So I say it is a big deal, and we should do a lot. We should do a lot for the other things. I think the amount that we've done for COVID has actually, in retrospect, been about right. Had we waited another few weeks to lock things down, I think the whole country would have been like New York. And we couldn't have handled that, because how we handled New York was places that weren't quite as badly hit could send things to New York, but if everything was badly hit at once, we wouldn't have been able to rescue each other. So this really is important. And I think I'd kindly to say, just talk to anybody who's from New York and say, it's not such a big deal. So I had a meeting this week with a friend from New York, and he said 12 relatives die from this disease in New York. I mean, we all have a few relatives who die of something, but to have 12 relatives in such a short time, truly heartbreaking. So Kim asks, we've had 2 positive cases in 2 days, but you keep saying no presumptive cases. What's a presumptive case? So a positive case is somebody who has a positive test. We got that. A presumptive case is somebody who has a contact to a case and has symptoms like they have it, but they don't yet have a positive test. So, for example, let's say I would come down with it. I would have a positive case. My wife would be at home. If she had no symptoms, she'd be a contact. But if she had symptoms, as soon as she had symptoms, she would be a presumptive case. If she then was tested and was positive, she would move from a presumptive to a positive. Or if she still had the symptoms and later it was found out, oh no, really, she had strep throat or something else, it would go off the rolls. Now, most of the presumptive cases stay on the rolls, and that's what they are. We've just not had any in that situation. Typically, for every case, for every 50 cases, there's a couple of presumptive cases. And since we've had so few cases, not surprising that we've not had any presumptive cases. Yeah, pool tables. Crystal, you are really into those pool tables. I don't know. This is about, will pool tables open in phase 2? And I don't know the answer to that. The sector guidelines. So Oregon has picked a slightly different approach to opening sectors. So in some states, I think what's happened is the health department has said this can open, that can open, this can open. Actually, in Oregon, what's happened is the industries have worked on guidelines and then have worked with public health to be sure that they're going to be appropriate. And because of that, actually, public health doesn't see them early on. We see them late. So I haven't seen about pool tables. But as soon as we have that, Crystal, I'll send you a note. So somebody says there has been one person hospitalized for a while. Is this the same person the whole time or different people? It's unfortunately the same person. So this person is really, really, really sick. But as we heard today, slightly improving. So being able to sit up at the side of the bed, hopefully getting to the point where they're going to be able to get off ECMO. So really, our thoughts and prayers go to this family that's really been through the ringer. And this relatively young person. So as much people say, oh, the only people die of this are people in their 90s. It's really not true. There clearly are many people in their 70s, 80s, and 90s who do die of this. And then shockingly, some people are over 100 who get through it. But then there are a lot of people in their 30s and 40s and 50s who are either die or are left terribly injured. So this really is important. I grew up in New York City. You probably can't tell from the accent, but I grew up in New York City, and when I hear stories from back at home, from people I went to school with and whatever, or family, it really is kind of heartbreaking. Yeah, so this is one of the things we talk about is wearing masks. And so if you're not used to wearing a mask is a distinctly unusual and uncomfortable thing. So you put it on, and the air you breathe is immediately hot. The air you breathe is hopefully a little bit filtered. And you feel like you can't really get a good deep breath in. You really don't feel like you can breathe all the way. And so it's problematic. People can get a lot of anxiety with masks. So for anybody who's at least been claustrophobic, wearing a mask is really quite difficult. And they're worried. Now, we do know that the oxygen level decreases a smidgen and the CO2 level goes up a smidgen, but you know, oxygen levels go down a smidgen all the time. I mean, every time we drive to Diamond Lake, the oxygen levels go down way more than wearing a mask, and we don't really think much of it, probably because it happens slowly and we're not aware of it. But I will tell you, when you wear a mask, especially if you don't like wearing a mask, it can be pretty darn uncomfortable. So what are my recommendations? Well, my recommendations are, if you really hate wearing a mask, don't wear a mask. You can find some masks that are much more comfortable than others. Masks that are a little looser fitting still work and are perfectly good. Some of the really gauzy masks probably don't filter as much, but they work. And the deal is, I really hope that people don't get too hung up on masks one way or another. I've heard both. You can't come into my store unless you're wearing a mask, and others, you can't come into my store if you're wearing a mask. Guys, it's not, masks are great. Masks are one of the things that we can do, but it's not the be all and end all. As you've heard me say again and again, the most important thing is stay home when you're sick and socially distance. If everybody did those two things and did them well, we would have much less of a problem. Can the roller rink open? I don't know. So again, we haven't seen the specific guidelines, so we don't know. Roller rinks will be a little bit of an issue in that it's a little hard to enforce social distancing unless you're a great skater. My son especially loves to roller skate, so he was looking forward to opening. So Denise says, what's the current thoughts on herd immunity or folks being exposed to help get herd immunity? So herd immunity means that you have enough people in the society who are immune to a disease so that the disease can't spread. So something we think about all the time. So with measles vaccination, you have to get to about 95% herd immunity so that the disease won't spread. And that's why we keep pushing measles, mumps, rubella vaccine, and we really do. And we know that when you get 95% immunity in a larger population, it doesn't spread. Now, what we worry about it with measles is that there are some populations that don't want to get the measles vaccine, and the level of immunity in those communities is low, and then you do see lots of cases of measles. Oregon does pretty well, and Southern Oregon does very well for measles immunity, so that's why we've not seen a case of measles in the 30 years I've been here in Douglas County, which is pretty great. So to get herd immunity for this, you'd have to get immunity levels of at least 60, but probably more like 70%, and it would need to be durable immunity. The concern is in even the worst hit areas, it's probably only 14 or 15%, and they've been through hell. So, you know, if you think of New York, if you think of Italy, they've been through a terrible time, and they only have 15 or 20% immunity, not nearly close enough to get herd immunity. The second thing that we're seeing is that the immunity from this, unlike measles, is not lifelong, and the immunity from this may only last 6 months or so. And so we're starting to see people who were positive before, even less than that, now starting to get reinfected. And when you look at the SARS antibodies, when you look at the antibody studies here, the antibody levels drop off pretty quickly. So if that's the case, then you'll never get herd immunity. And there are a bunch of diseases for which we can never get herd immunity. So for example, norovirus is like this, norovirus, the cruise ship vomiting virus. And the reason we get big outbreaks of that is you don't develop good immunity to that. You might have some immunity in the weeks after, but within a few months it falls off. And so you could get it each year when you take a cruise, which makes it kind of ugly. So we don't know how long the immunity lasts. We don't know how protected the immunity is. So I think the idea of moving up to herd immunity is very worrisome. I mean, you'd have to go through lots of deaths. I mean, you'd have to get to thousands of deaths in Douglas County to get to enough people to get herd immunity. And then wouldn't that be a kicker if you did that and then people got it again? So I think right now the thoughts on herd immunity is that this is not the strategy to go. we're having a good experiment, right? We're seeing what's going to happen in Sweden. We're seeing Brazil at one point had said they were going to go for herd immunity. We'll see what happens in those two countries. I think so far the experience there hasn't been something we would want to do. Yeah. So Kelsey says, what kind of follow-up is being done long-term for those positive cases? Can a positive COVID trigger an autoimmune response? So for people with who were sick and a long-term thing, they are being followed up with repeat chest x-rays to be sure that the lungs are improving, and with oxygen levels and other kind of pulmonary function tests to be sure that their lungs return. Actually, some of the early data suggests that those people have done well. Other people who had more severe disease are still recovering, so we'll see that happens. We do know that their CT scans improve, not all the way, but are much improved with time. So I think there's going to be a lot of lung recovery. But as we'd said in the past, you're sort of born with the lungs you have, and once you start to damage them, it's really hard for them to really recuperate. So these people may be left with some long-term lung damage. The second is, can a positive COVID trigger an autoimmune response? Well, we certainly know in kids that this multi-system inflammatory disease that we see in kids is almost certainly an immune response out of control. Whether it's autoimmune or not, we're not sure, but it's certainly an immune response out of control, and we certainly know in kids and young people that can happen. Whether it triggers a more indolent autoimmune disease, we do not know. So Lori says, do all autoimmune diseases put you at greater risk like Hashimoto's? I do not know. So when I looked this up on autoimmune disease, they just lump them all together. So they lump lupus and Hashimoto's and all those things together. And as we know, there are certain autoimmune diseases which are far more serious than others. Now, Hashimoto's is not good for your thyroid, but it doesn't affect the rest of your body very much, whereas lupus can really affect everything. So I'm sure as the data gets out there, they'll be able to split out these autoimmune diseases to see. So what would it look like if we got to phase 2 and then have to go back to phase 1? Well, everybody certainly hopes that doesn't happen. That one I think will be demoralizing. So it will really be demoralizing if we get to a place where businesses start to open and then they need to close again, if people who get back to work need to leave work again, if some of the things that we can do go back again. So we are trying so very hard not to go there. And that's why when I talk about our efforts, the efforts now have really got to be the most stringent from the public health point of view. We need to be testing like crazy. We need to be tracking down every one of these cases. People still need to do a good job with social distancing and staying home when you're sick, wearing a mask if you can. I'm not telling people to do it if you don't want to. Wearing a mask if they can, washing your hands a lot. Those are the things we do. Testing is certainly going to help, but our testing positive rate is 1.2%, so it's pretty unclear that testing more would help that much. So Laura says, is it true that somebody with kidney disease has a higher chance of catching COVID? We don't think there's actually a difference in catching the COVID, but we do know that people with underlying health conditions are much more likely to get symptomatic and are much more likely to be so sick that they wind up in the hospital or the ICU or dying. So I don't think the kidney disease actually causes you to catch it, but I think the kidney disease very clearly causes you to be at great risk. So there have been a couple of new things about that have come out this week. Remdesivir still looks like it's going to work. It was finally, the study, which I said, boy, I wish they published it, was finally published this week, and they read it in great detail. Looks like it's going to be, as I said, not a home run, but a bunt single. And anybody who plays baseball would always take a bunt single. And so, it shortens length of stay, which is great. The trend was to lower mortality, although it wasn't statistically significant. There weren't a lot of side effects, so that was good news. What's probably best on the remdesivir news is this is how we make progress. So I got to be on a panel this week, and I don't know why they picked me, but there was this guy from Harvard, and there was a guy from the FDA, and the little Bob Dannenhoffer. And so these guys were saying, look, if you look at the way we've developed really great therapies for things, it didn't happen with the one day somebody says, I know the answer here. What happened is we started with something that worked a little bit. And then we found something that worked a little bit better and a little bit better and a little bit better until we got something that worked really great. So early in my career, very early in my career, HIV came out. And, in fact, when it first came out, I saw one of the very first kids in the entire country who had HIV. And, this was a time there was nothing. And this poor little girl had it, and within a few months was dead. Then later in my training, there was another little girl who got it through transfusion, and she got it, and she was dead in a little bit. I then took care of a few hemophiliacs. There was no treatment. Well, then in the mid '80s, we started having some treatments. It wasn't very good. It was quite toxic. Didn't really help that much. Had so many side effects. But we didn't give up. But we said, well, maybe we'll change. So the first was AZT, and then you went to another and another and another. And now and then after 30 years, there was treatment for HIV, which was so good that in almost every case we can suppress it to zero. For hepatitis C, for years, there were all kinds of different things that were trying with interferon or whatever else. Lots of side effects, not very effective. But now, over the last 5 years or so, there's incredibly effective treatment for hepatitis C. So what remdesivir shows us is that something can work. And maybe remdesivir plus something else, maybe remdesivir and then remdesivir 2 will work a lot better. So the fact that something works is very good, but now we're going to need to work on something else. The problem, as these guys said, although we put a tremendous amount of time and money into HIV, still took 15 years. And hepatitis C, there was a lot of money in hepatitis C, still took 15 years. And the concern is that although there's a lot of money in this, it's still probably going to take more than a few months. It may take years. Other things we'd heard, Pepcid, weirdly enough, Pepcid, a drug used to treat heartburn, actually did seem to be effective in a retrospective study in China and a prospective study in the US, so we may hear more about that. Hydroxychloroquine probably doesn't work and probably does cause some heart things. They're now going to try hydroxychloroquine as a preventive. We'll see what happens. For vaccines, there's 10 in human trials, and those 10 vaccines in human trials, that's a good thing. But one of the other guys on this panel was a vaccine development expert. And he said, yeah, vaccines are great, but they always look great and at the early stages. But whether they really work and whether they really can prevent disease is always a big step. So his sense was, it's good that we have 10 to pick from. It's good that we have all this stuff going on. But anybody who thinks you're going to hit a home run the first time, pretty unlikely. Yeah, Gene asked, what's a safe distance for singing with friends outside? We do not know the answer. It's interesting that singing appears to be one of the most dangerous activities. And so there's something about singing, I think when we sing, we project and we have lots of particles. That seems to be that. In addition, when we sing, we tend to open our mouths. And when people open their mouths, take deep breaths, they may be breathing more of this in. So I do not know. Outdoors, always safer than indoors. 6 feet, always a good start. 10 feet together outside, probably safe. So Justin said, is there a reason Oregon ranks 49th in testing per million population? Again, the testing per million population is such a foolish number. Really, if you had no disease, to do a huge amount of testing makes no sense at all. Far more important is, what is our test positivity rate? Far less than 5%. What is our overall attack rate? Very low. So when you actually look at the testing per capita, that is a scatter plot between states. However, if you look at positivity and results with it, it's very clear that test positivity is the way to go with it. Right now we have plenty of tests. In fact, we have all this testing that we do at the fairgrounds. We even do it for asymptomatic people, and we're never even close to full. So the reason that we're ranking low in testing is there aren't a lot of people out there who need testing. Now, in Brazil, with 50% positive rates, they need to do so the point is, you should do 50 tests for every positive. So that would be the case. So that would suggest that in Douglas County, we should have done 50 tests for the 27 positives. So that would be about 1,500 tests. We've done far more than that. Whereas if you look in New York or Brazil, New York would have to do another 5 million tests. The country as a whole with about 20,000 cases a day times 50 should be doing 1 million tests a day, and we're not even close. So really, I think what happens is you should do testing in areas that need it. In the areas that don't need it, probably the resources should be shifted to the places that do need it. So Laura says, with the new inflammatory response disease in kids, is that a concern for schools opening in the fall? Yeah, I think this disease is a big concern. Again, the kids who had this were not very sick when they had the disease, but they were sick later, and it seems really to be related to the background level of disease. So if you look at the places where there have been outbreaks of this, it typically is in areas where there's been a lot of disease. So a lot of cases in New York, a lot of cases in Connecticut, a lot of cases in Boston, all places where there was a lot of adult disease. In Oregon, just a single case. In Portland, where there's been a lot of adult disease. A case today in Houston where there's been a lot of adult disease. So really the key is decreasing the level of adult disease rather than doing anything special for kids. Because again, this is a rare thing in kids, which we think is an absurd immune response to the COVID. So really what we need to do is keep the rate low in adults. And so I don't bore you, socially distance, stay home when you're sick. If you have symptoms, get tested. So Dana says, during the flu season, do you think we will see a rise in testing? Yes, because I think when the flu season comes, there are going to be more people with fevers and body aches, and I think everybody with fever and body aches should be tested for the flu when the flu's out and for COVID, because the only way to know is to do that. So for example, one of our new cases had just like a flu-like thing, no cough, no shortness of breath, no diarrhea, not the things that we typically associate with it, but just sense a flu-like sense. And their doctor was very smart in ordering the test and it was positive. But unless you're going to test those mild people, you're never going to find it. But again, the thing that's remarkable is everybody who comes to the drive-in, almost everybody comes to the drive-in, think they have it. And 1% do, so that means 99% of the people who have this kind of stuff have something else. Yeah, Linda, you just asked the question. So with all the negatives we've had, what are they sick with? Do they have a common cold? Do they have the flu? How are they getting it with all the precautions being taken? Well, we, in our drive-thrus now, we're doing mostly pre-ops, people with mild symptoms. We do have some data from the Seattle flu study that's not fully out yet that suggests that the people who were sick in Seattle during the time when there was a lot of disease who did not have COVID had some other typical viruses. They had things like metapneumovirus. They had things like the other coronaviruses. They had stuff like rhinoviruses, all of which can make you very sick, and those are the people who had it. I think when we look at the number of people who are sick with colds and flu-like stuff, it's very low. So the state measures a thing called COVID-like illnesses in the emergency rooms. So when somebody comes in, if you have the symptoms of COVID, they put you in the COVID-like category. We were about 7% COVID-like disease in March. So in the second or third week of March, we were about 7% of this COVID-like illness. That was a high number. We're down now to less than 0.5%. So there really is very little, cold and flu stuff going around now. And some people are taking precautions, some people not. But really the amount of background disease is way down. So how long will the testing site be available? Throughout the rest of the year? The answer is as long as we need it. People always say, well, it would be really great if my job could go away. In this case, it would be so good for this job to go away. We're going to continue to do it as long as we need it. We're doing it twice a week here in Roseburg, and then in the weekends in Reedsport. Again, if you want to get a test, call your doctor. If you don't have a primary care doctor, there's a number at Aviva that you can call, which we'll put in the chat box, and give them a call and you can get a test done. I think when we started off, there were a lot of people who wanted a test who couldn't get it. There were a lot of symptomatic people. We're now to the point where we're doing a lot of people who are asymptomatic who want a test, people who are asymptomatic who are looking to have it, who are preoperative for surgery, people who just want to know if they've had it, and then a few symptomatic people. So we're going to keep doing it. Well, one of the other things I want to talk about is super spreader events. So on this call over the week, one of the guys from Harvard was totally into super spreader events. So when we think of most diseases, cold, say, or strep throat, you tend to give it to a couple of people in your house. So, the typical story is, oh, my best friend had strep and now I have strep. My girlfriend had strep, now I have strep. Where someone in the family gets strep and then the brother or sister gets strep. So you can almost always kind of see where it came from. And I don't think I've ever in all the years had a kid with strep who's given it to more than a few kids. And so that's the typical way that things spread. This disease is so weird in that now that we're understanding the spreading characteristics better, there are many people who give it to no one. So somebody gets it at work, they bring it home, they don't give it to anybody in their family. How in the world does that happen? How do you not spread it to anyone in your family? In some cases, they give it to one person, maybe their spouse. In some cases, they maybe give it to everybody in the family and maybe some outside. But then there are a couple of people who give it to a lot of people. And the stories of this are just stunning. There's the guy at the cocktail party gives it to 40. There's a person who goes to a meeting, gives it to 4 other people in the room. There's a story of this person in a Seoul religious service who gives it to, they think, 1,000 people. There's, and this story this that came out this week was about a cruise to Antarctica. So, at least from Argentina, where there's some disease in Argentina, so they screen everybody before they go. There's 128 passengers and 95 crew. They're on a trip to Antarctica, so they are totally isolated except for the penguins. On the 8th day, one comes up with fever, and then a few days later, there are 8 very sick people, really sick people. Of those, 4 wind up going on a ventilator and 1 dies. I mean, that's really sick. I can tell you never want to be on a ventilator. And so that was the story. They went back and tested everybody else on the boat, and they find that there are 128 positives on the boat. So there's only 200 some odd people on the boat, and 128 are positive, and 108 of them have no symptoms at all. And thus, the concern on this is obviously a really bad disease for the people who got it, but all those people are asymptomatic. And how did one person on the 8th day spread it to all of these people? And the answer is we don't know. And that's why we worry so much about the super spreader phenomena. And I think the reason we've been lucky here in Douglas County, super spreader phenomena occur uncommonly, maybe 1 in 100 times when somebody is sick. And because we've had a low number of cases, we've not had super spreader events. But if we had 100, 200, 300 cases, we start to see these super spreader events. And that's, I think, why it spread so quickly. So in New York, in New Rochelle, they had one guy who's a lawyer who got this. We don't exactly know how he got it. He was a super spreader and spread it to at least 52 other people, although he didn't do anything that unusual. He went to work, went to a funeral, somebody drove him to the hospital. He did those kind of things and infected everyone around him. And so I think in Douglas County, we have been lucky because we've not had a super spreader event. And so the super spreader thing is just the weirdest thing mathematically. It suggests that absent the super spreader events, this would be a nothing. With the super spreader events, the chance for this enormous quick spread is there. Now, one of the things that's interesting when they look through the super spreader, none of these have happened with kids at school. That's pretty striking. So none have happened with kids at school. And it might be that kids themselves, because something about the disease, they tend not to have high viral loads and they tend not to be super spreaders. So that gives us a little bit better feeling about opening up schools. Unfortunately, there's some of the things we're talking about opening up which really are super spreader events. Singing concerts seem to be high on the list, and it may be because you're singing and having your mouth open a lot and having a lot of viral particles go out. Church services are a high risk. Indoor sporting events are a high risk. We think perhaps one of the reasons that meatpacking plants and other industrial plants are high risk is because it's loud, and when people talk to each other, they don't talk to each other, they yell at each other because it's a loud environment, and that may increase the droplet spread. But this super spreader phenomenon, truly amazing. Okay, has there been any more information released about ivermectin as a treatment, Jedediah says. So ivermectin is an anti-parasitic drug, and there was something about ivermectin. There's something like every day there's 3 things about something else. You know, again, people get an idea that I might work for some reason. I also saw someone today about the drug that they use to treat Gaucher disease. So Gaucher disease is a disease where your body can't make the enzyme that breaks down extra myelin products. So it may be that this will also break down the lipid thing. So people have this idea, and then what we should do is we should easily and quickly test it. Ivermectin is cheap and it's around, so it would be not unreasonable to try ivermectin. But again, for all of these things that look promising, as the guy from the FDA on this call said, only about 1 in 50 works. So, you know, be it Pepsid, be it hydroxychloroquine, be it all those, I have no problem with people suggesting these things. But then rather than sort of willy-nilly taking them or whatever, we can do the studies. And because there's enough disease around, and because people are concerned enough about it, you usually can get a pretty good result pretty quickly. Now, to get a really precise thing, whether it decreases death rate by 2% or 5% or 8%, that does take a lot of patience. But whether it's sort of helpful, you can do with the first 50 or 100 patients. So ivermectin may work. There's no specific reason to think that it would. Ivermectin kind of interferes with cell division. You know, viruses aren't cells, so it might or might not work. But what we found in medicine is a lot of times things that are developed for one purpose don't work for that purpose, but work for something else. So, for example, remdesivir, which we've talked about tonight, remdesivir is not, you know, was developed for Ebola, didn't work, but does seem to work a little bit for this. So that's kind of how we work in science and medicine to get these done. All right. Other things that we want to talk about, so let me get them all here. Got one more question. So with things opening up, does it make sense to increase testing of asymptomatic people? Maybe. You know, testing of asymptomatic people has been profoundly unhelpful. So they're doing some studies. So there's a thing called tracer study in Corvallis. And what they found is about 1 in 1,000 people is asymptomatic and positive. And then when they're asymptomatic and positive, you say, that's interesting. And then it's not exactly clear what you do because they're asymptomatic. Do you quarantine them? Do you quarantine others? Since they're asymptomatic and around everybody's been symptomatic, it's hard to know what to do. So we're not exactly sure what we're going to do with asymptomatic testing. We are doing asymptomatic testing now for anybody who wants it. There haven't been very many. We are going to do some asymptomatic testing for people who work with old people, just to know. We're going to do some asymptomatic people who are working in a packing plant, just to know. And we're doing asymptomatic testing of people on fishing boats, just to know. But it's not really the way to do it. So if you look at the countries that did a great job with this, what they did was they tested everybody, even with mild symptoms, and then they tested contacts of cases. So, for example, in Korea, where they did probably the most extensive testing, they tested, when somebody at the church was positive, they tested everybody in the church population, but they didn't go to other villages where there was no disease to test. And I think that probably is the best strategy. Now, interestingly, Japan has done a good job on this, and they haven't done a lot of testing. They haven't done a tremendous amount of testing, and they did this by avoiding crowded places with poor ventilation. So that's one of the other things that we're going to talk tonight about, poor ventilation. Ventilation probably does make a difference. So the number of air changes per hour does seem to be important, because when they've looked at places where there have been these super spreader events, they've typically been in places with poor air circulation. And places with better air circulation, like outdoors in a windy environment, the case rates are very much lower, suggesting that air circulation does make a difference. And the reason we think that outdoor activities far safer than indoor activities. And so HVAC does seem to make a difference. All right, well, it's a beautiful summertime day. So I think that's what we got for the day. We're just about time. Again, if you have more questions, you can put them on the chat. If there were some questions we didn't get to tonight, I'll look at those tonight. And then otherwise, we'll see you back on Monday. Again, Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County.
Thanks.